My name is Charles Boicey, and I'd like to welcome you to my presentation entitled Modern Data Architecture to Support Healthcare During a Pandemic and Beyond. Before we start, a little bit about myself. I consider myself a clinician first, technologist second, and then a professor third. So my clinical background is trauma critical care nursing. I ran the trauma unit at the LA County USC Medical Center for a number of years before I made the transition into both biomedical engineering as well as biomedical informatics, and then continued on with computer science and technology management, and as well professor of applied informatics at Stony Brook University. So that's enough about me. What I'd like to talk to you today about is we're gonna kind of cover some of the the architectures that support healthcare currently. We're going to do it from a pandemic perspective, as well as even kind of venture out a little bit into kind of a more of a futuristic, but with technology that is currently in our hands. So with that, I would go ahead and like to get started with you. So if you think about healthcare and all of the various components of potential data that really makes up a person's well-being or healthcare, you really got to take everything into consideration. Because if you think about it, from a patient perspective, you're only in with the clinicians for a certain amount of time, right? Even if it's a hospitalization that lasts, a week or so, it's still only a week out of the year. In your clinic visits, when you go to see the, your provider, annually, or when, you have a condition that needs attention, you only see them from a very short period of time. So, data collected during that period of time is only a part of it. It's very important that we not only collect that data from your encounter with us, but also data external. So, that's why you see what you see in front of you, all the various aspects. And this is just a small, sampling of that which is out there. So if you think about, social determinant data, that's income level, that's where you live. If you think about, staffing data, ERP data, claims data from the EMR, the actual electronic medical record, that data which is collected during your visits. We have genomic data, data, about your genome sequencing, et cetera, imaging data, whether they be, X-rays, CTs, ultrasounds, MRIs, so that type of data. Social media data, what is the general mood of any particular group at any particular time? That can be derived from, Twitter feeds, from Facebook, from Instagram. Laboratory and pathology, what do those lab results look like? Exposome data, very, very important. That is the data around you. Air quality, traffic patterns, humidity, temperature, ambient light, noise levels, things of that sort. Pharmacy data, whether you're on medications, that data is important. Services that are being provided, health and behavior, your physical health is one part of the equation, but your mental health is another part of the equation. And then we have streaming data. We have streaming data from all kinds, both within a healthcare organization as well as external to a healthcare organization. And what do I mean by that? Inside the hospital, you have streaming data from all the instruments, the physiological monitors, the ventilators, the smart pumps, basically anything that puts out a signal in the hospital, anesthesia bench, as well as external. And one of the use cases we're going to talk about towards the end really is about that type of data, data that we actually produce on a daily basis from our cell phones, from our wearables, and so forth. So I think you've got a really good picture now of the need for a modern architecture that is very much, from an application perspective, is containerized, and from the ability to grab data from multiple sources, very, very API centric. So let's go ahead and let's continue. I'm gonna get into a little bit more detail than this, but I just wanted to, initially start with just a regular representation of an architecture, kind of going up from the top, and then we're going to get into it a little bit more, if you will. So I practice within a private cloud environment, and I've done that for several reasons. One, because it's healthcare, I needed control on the environment, so that gives me total control on the environment. High trust, SOC, various ISOs, HIPAA, of course. But it's really important that we're not making a choice from private cloud, public cloud, on-prem. The choice has already been made. We're going to need to utilize all of those environments. So if I start in a private cloud, I better have a API layer that lets me connect to anything out there that I might need to connect to. And really that is a hybrid approach, right? So from a hybrid approach, if I have a client or I have a need to run something in Google BigQuery, I better be able to accomplish that from my environment. So the lesson here is we don't want to box ourselves into an architecture or box ourselves into we can only work in a single environment. It's really important that we're able to take advantage of other environments because they're out there, and there's not necessarily a need to build everything within our environment unless we absolutely have to. Kind of moving up, I'm a proponent of both hyperconverged as well as composable. I've actually combined both of them. And what does that mean? That means from a composable infrastructure, I can scale up on compute memory or scale out on storage using very, very low cost, commodity hardware, and then put a hyperconverged layer on top of that. That now gives me the ability to work in an environment that is bare metal, virtual, containerized, and now serverless. Very important that I'm able to work in that type of environment. Kind of going up a layer, a Hadoop infrastructure. You're probably going, what the heck, why? Well, think about what I just talked about, those various data elements, various data types. They need to land somewhere. They need to land somewhere to start the process. That may not be the end all, but it is a proper place to do that. So you think about HDFS, what it has to offer, HBase, what it has to offer. We talked about streaming, being able to stream data, via NiFi, and if you have some need for Spark in that environment, you have that. But a good environment, clustered environment, distributed, is a really good place to handle all those data types as we go up from there from a processing perspective. Then you think about a little bit higher level than that, a transanalytic environment. What does that mean? An environment that allows us to perform transactional, also allows us to do BI as we know it, as well as advanced data science in that, data governance, data pipeline, as well as data discovery. In healthcare, there are many ontologies. There's about 7 that we work with on a daily basis. You absolutely need data governance around that. Data governance is really key to being successful in managing data within healthcare. And of course, a data pipeline to take it from a raw state to something that's absolutely usable. We kind of go up to the next layer, an environment that I'll get into in a bit that can handle both proprietary applications as well as third-party applications. So think an environment that allows for service mesh architecture, heavy microservices, and again, very much API centric, containerized, Kubernetes, and Kuma, and the rest of the components that make up modern application architecture that can communicate not only with data within this environment, but can also communicate via APIs to environments external to the home planet, if you will, or the home environment. So that's kind of the ABCs, the basics. Let's get into it on a little bit more detail. So let's kind of take a look at it from left to right. We saw the different types of data. They normally come into a healthcare environment from a push or a pull. So a pull is where we're grabbing data, and that can be, batch or, direct connect. This is where interface engines, can come into play, or, RESTful APIs, or push, where data is, pushed to us. Again, an interface engine will accomplish this. This is where I bring NiFi into the picture. HL7 is a familiar standard within healthcare. Streaming HL7 messages, as well as from a Fire API, we can also bring in those, Fire type messages. And then taking it a little bit more from left to right, bringing everything in its total, in its native state. Why? Well, healthcare from a data perspective is rapidly maturing, and it's best that we leave no data behind, because as we build out clinical models, operational models, models for research, there will be a need for that data. There'll be a need for that legacy data. We can do a lot more with 25 years worth of data than we can with 1 or 2 years worth of data. So data comes in, we can then produce insights on it. What does this data look like? Sometimes we may have schemas, we may not. We may know all the relationships, we may not. We throw AI against it so that we can understand a little bit more. I talked to you about the governance process, and ensuring that data governance is very much baked into the equation. And I'm going over this stuff light. I'm going to have some contact information at the end. We can absolutely get into it if you give me a call. And then convert. So it's one thing to land data, it's another thing to process it. And we'll get into that in the next slide. So processing it so that it is at an endpoint. So we've taken the stance that I'm not interested in the endpoint. I'm interested in bringing the data in and then applying a schema to it when I understand what that endpoint is, as opposed to coming up with a bunch of dashboards, coming up with whatever those data science products I need, whatever those applications are, and then going back to sources and hunting for that data and doing an ETL process. That's super laborious. And we all know that once we've done that for something, then we got to go back, far better to bring everything in, apply a schema to it initially, and change that schema as the requirements change. Can do that in a much quicker time. So within this environment, like I talked about, the ability to not only build out applications from a containerized microservices service mesh approach, but also to host applications or technology that is adjunctive to the environment. And also important in a healthcare type environment is a healthcare organization may have tools that they would like to use. Yes, within this environment, R, Python, Jupyter, Zeppelin notebooks, of course, but what if I'm a Mathematica, SAS, or SPSS, or JUMP user? I better have the ability to connect and work within this environment. So as well as then, produce for, external users and so forth. I know this is very basic, but the real points that I wanted to get across here were coming from the slide before. We have all different kinds of disparate data, bringing it into a place that we can work it, and then starting to work it. One of the things that I spend most of my time on, and that I've been very very diligent with and spent my research efforts on, is to build out from a data processing perspective, from a data pipeline perspective, to build out some robotic process automation components within that environment. Healthcare data in its raw state contains both discrete as well as textual data. Again, we talked about ontologies and so forth. So let's kind of take a look at that middle section. And again, we discussed, we've already had that discussion on what it looks like from a data processing perspective, data coming in both push and pull via APIs and so forth. Now it's kind of landed in our environment and it's making its way through. From an API perspective, in a process perspective, it's really important that we don't want to continually, let's say we have the first, like you see, we have a natural language processing capability within that data pipeline. So basically we can send documents in that pipeline out to extract information and then further enrich it through the pipeline, as opposed to now I've got to bifurcate that pipeline. I've got to manually go do the NLP and then bring that data back in and complete that process. This is making a call out to our NLP services and then bringing that back. In healthcare, going off to the next section, we talked about all the different ontologies. So if I've got laboratories coming through and they're not coded with a LOINC value, or that LOINC code is incorrect, I need to correct that at this point in time as the data is passing through, not passing the data through and then correcting it manually and or using a service. Many times in research, it's very important that from a HIPAA perspective, that data is de-identified and or obfuscated. So doing that data DID or obfuscation, depending on what the use case within that data pipeline. Again, API call out, that data is obfuscated or DID'd, it's back in the pipeline. And in healthcare, it's really important that we understand who those patients are, and that we've given them a proper identifier, and that we don't have any duplicates, running around and stuff, so that we can, combine. But you kind of get the picture. So when we go from, left to right in this environment, we now have the ability to take advantage of that API library and those other resources external to the data pipeline that may be within the environment, or they may be a service that we call on in, let's say, AWS, Google, or another part of the ecosystem. And when we get into, and we're going to go into the use cases next, it's really important that you understand that a lot of this was developed so that data can be accessed externally, that normally is not within the confines of a healthcare ecosystem, if you will. So let's talk first about our first case. And this is one of my favorite organizations, Meharry Medical College, who made the decision 3 years ago to put up a data science institute and to be completely data driven, and not only their care, but also their education. And what I really like about them is they're now graduating medical students, not with just MDs, but now with a certificate in data science and working on master's level and PhD as faculty grows within the environment. So how cool is that, graduating physician data scientist? So let's go back to the story here. So the story here is Meharry Medical College is in Nashville, Tennessee. It's in an underserved community, primarily African-American community. Meharry Medical College is an HBUC, historically Black university or college. That's the population that they served. And as COVID first started, entering, the hypothesis that we generated was, is there disparity in identification? Is there disparity in treatment? Is there disparity in outcomes, in mortality in this community? And can this be extrapolated across other similar communities? So what did we do? So we had that hypothesis, and what we did is we put together, in this case we used the Clearsense environment. We used our environment. We used APIs external to all the various data sources where we could bring in COVID information from a population perspective, as well as from an actual clinical testing and so forth. So from an API perspective, bringing all this public data that's available, and then bringing in all of the data that we had, clinically. And I have a visualization of this information that you're more than welcome to go take a look at in Tableau Public. And what did we find that was of interest? Yes, we were able to show that within the African American population in underserved environments, there was a disparity in diagnoses, treatment, as well as outcomes. So later, a little bit later, coming into, in for treatment and whatnot, and so forth. But we made a really, really interesting discovery in this. We also discovered, regardless of race, ethnicity, rural environments also had a great bit of disparity as well. Their mortality rates were high, and treatment was delayed as well. So COVID affected the rural environment much differently than it did the metropolitan environment, as well as from communities of color, affected them as well in a different way. So we wrapped all this data up. We were able to present it to Dr. Hildreth, president of Mary Medical College. He was able to bring that to Congress on May 29th, and was able to show the case. And was able to really make the plea that HBUCs, or historically black colleges and universities that have academic medical centers, really should be the place of where this type of research is being done. So again, this would not have been possible without the ability to capture all of that data from both a streaming perspective and from an API perspective that public data sources. So use case number one in COVID, and then going beyond. Oh, I've got some additional. Forgot about this. So think about it. Everything stops. What kind of effect is that when everything stops? And as you know, everything did stop. Everybody switched to preparing for COVID cases. So a lot of elective surgeries were canceled. A lot of those elective cases I wouldn't consider. If I needed a knee, that's not elective. So we had to take all of this data and then help prioritize those surgeries as things ramped up. Think about all of the outpatient visits that were dependent on medications, the brand new type 1 and type 2 diabetes, putting in a pathway for them to be treated, the hypertensive patients, patients on anticoagulation therapy, they had to be identified immediately. And again, a data science, a data exercise, and then be connected, via, Zoom and other telemedicine methodologies to get them, back in line. A lot of products were built, data science products were built for supply chain and capacity, personal protective equipment, ventilators, medications, and so forth. And what are we doing now, and what will we be doing in the next several years? We'll be doing analysis on this data to help us better prepare for a pandemic. Okay, so let's move on to the and beyond. I want to then talk about, from a API perspective and a real-time perspective, what we are doing at the University of California, Irvine's Institute of Future Health. So what we've determined, and what our mantra is health is not just the absence of disease. Health is, like we talked about, a lot of environmental factors. So what can we do as technologists to enable citizens in a low-cost way to be able to manage their health? So if you think about it, at some point in the future, we'll see practitioners for some type of disease, an accident, or if we have some genetic disposition that requires us to be seen. But again, the goal is to manage as much as we can ourselves. So again, think health state, not disease state. So if you think about states, states are changing, and what's necessary to understand a person's state, if you will. We need all kinds of data. We need to be able to understand a person, not just from a population perspective. Take me for instance. I'm not just Charles that has a hypertensive condition. I'm Charles, part of a population that does, but I am still unique, and I still need to be treated uniquely. We don't treat all hypertensives. We don't treat all folks with diabetes the same. We have to treat them as individuals, although they're as a group. So as more and more data comes in, we know more about from a neuro state, GI state, cardiovascular, respiratory, etc. So again, think health states. Also think about activities that you do anytime during the day. It can be, eating. It can be the effect of, the environment around you. We talked about all the different, characteristics and whatnot. By collecting that data in context of what your experience is, then we have the ability to help you along the way. How much time do you spend commuting? What was your heart rate during that? What was your blood pressure during that? What was your SpO2s? That sort of data. What was the other environmental data? What was the traffic patterns, et cetera, during that period of time? So that we can, this is a huge diagram, if you will. I'll go through it, somewhat, but, you can, only, get so far, but we'll kind of go through it. So again, we're collecting a bunch of data, streaming, we're processing it. We're calling your 24-hour chronicle, your 24-hour experience personical. So that's you, combining it with your genomics, combining it with what ends up being all that external data that we talked about, where you have a personal model about yourself. We can then estimate your current state at any particular time, give you guidance, maybe notify a provider, but again, influence you to change your behavior. And then we have a feedback loop, or we have a cybernetic loop. So we basically have a continuous loop of how you're doing, presenting data information back, then how are you doing. So it goes something like this. I'm a diabetic. I just ate 5 donuts at Krispy Kreme on the West Coast, at Dunkin' Donuts on the East Coast, and now my blood sugar is up. I need to do some exercise. I've been prompted for that. I've also been prompted for, what to do from a lunch perspective. We take a glucose reading and we go from there. So you get the idea. We're constantly providing, feedback. And then if you take it from and even further, I kind of wanted to give you guys an idea of what this looks like, from an application perspective. On your left, you see, a 24-hour period, and you see all these spokes, if you will. Those are all events during the day. So if you go to the next one, we can then look at an activity level, versus a heart rate. We can bring in SpO2, blood pressure. Also present you with a mini exam, if you will, to understand. Let's say, hey, we've noticed that things are, your heart rate's picking up. We're not really seeing, a whole lot of, activity. You're not in an environment that should be elevating your heart rate. What is it? What's going on? And then, provide a, a little mini exam, and then provide some, feedback. Hey, you might want to get up and, walk around, or do you want, somebody to contact you? If it's a patient in a mental health scenario, we've given them a mini mental exam. Maybe we need to connect out to them. And then you see on the right hand side some again segmented activities, and then heart rate versus exercise. So this is the personical side of what we're doing. And again, the goal is to be able to use the technology that is provided for us, especially taking advantage of all those data sources that are accessible through free and public APIs, and then bringing that back together in an environment we can actually do something with. And then, one of the things I didn't mention before is healthcare can only handle maybe 9 nines to the right. And I'm being facetious and whatnot, but by containerizing, microservicing that environment, we now have products that are stable, that will remain stable, and that we can make changes to and upgrade without bringing everything down. Because you can only imagine citizens that are relying on an application such as this, they're not going to be tolerating any downtime and so forth. So last slide, I know I'm kind of going over and whatnot, but all of this data has now been collected. We can now do what we do as a data scientist and what we do as analysts and do best. Take a look at the data, understand what the data is telling us, understand the various patterns, and then produce new data science products, new interventions, based on all the data that we've collected, because we did it in a de-identified form and we haven't harmed the patient. So that is kind of the end all be all, is the ability to be able to take these data streams and actually be able to do something, so that at the end of the day, those interventions that you're getting, those are not canned interventions. Those are specific to you, which is really important, because then it's personalized and it's for you. With that, I'd kind of like to close. I really appreciate the attention that you've provided me over the last 25 minutes. If you have some questions, please feel free to ask. This is my contact information. I am an educator. If you have any questions, if you have any ideas, if you want to bounce anything by me, please reach out to me. And you can either reach out to me at the Clearsense address or at my Stony Brook address. So with that, we're going to close. And again, thank you so much for spending time with me. And I hope this was helpful. And if you have any questions, let's take some questions.